Hello, everyone, and welcome to the next session of CME Palooza Spring. I am Scott Kober, one of the co-producers of CME Palooza, and I would like to welcome you to our 80s movie-themed session for the afternoon titled Nobody Puts Outcomes in the Corner. And our moderator for this afternoon session is Amanda Hungry Eyes Kaczerski. Amanda is the Senior Director of Educational Strategy and Design at the Academy for Continued Healthcare Learning. So before we begin and before Amanda introduces the rest of our panel today, a few housekeeping items. First, we'd like to recognize all the sponsors of CME Palooza Spring, our gold sponsor, Academic CME, our silver sponsors, ASIM, Creative Educational Concepts, and Prova Education, and our many bronze sponsors, the Academy for Continued Healthcare Learning, Answers in CME, Catalyst Medical Education, Catamount Medical Education, Clinical Care Options, CMEology, Global Academy for Medical Education, Global Education Group, Helio.com Education Lab, Integritas Communications, Infograph Ed, Postgraduate Institute for Medicine, Primary Care Network, PVI, RMEI Medical Education, RedMed Ed, Thistle Editorial, and Vindico Medical Education. So there are three ways to ask questions for those of you who are viewing this session live. You can use the ASIM text line to send in a question. The number is 267-666-0CME, that's 0263. You can click on the Google Slide link found on the live page. This is a Scott session, so you can click on the Scott link and submit a question that way, or you can tweet your question using the hashtag CME Palooza. Any of those ways work. Any of those ways, I will keep an eye on things and ask questions of the panelists as we go through this session. So just be mindful that the opinions, discussions, and conclusions expressed are those of our panelists and do not represent an endorsement by or position of their employer, parent company, or its affiliates. So with that, I am going to turn this over to Amanda to get us started.
Thanks, Scott. Hi, everybody. Thank you for having us and joining us today. I'm really excited to be joined by this robust panel of colleagues. I have Greg Salinas joining us from CE Outcomes, Karen Ruiz Cordell joining us from Regeneron, Marlene Heeg from Purdue University, Mary Faulkner from AbbVie, and Chanda Iron-Browns from Novo Nordisk. And today's discussion is going to be centered on outcomes. And this morning we had a couple of great sessions. It does seem to be outcomes is always a hot topic. I think the morning session set the stage for some of the content focus of this conversation. I thought the outcome standardization project really also can provide some interesting fodder for this conversation. So I'm going to start right off the bat with a question to, let's say, Mary. What do outcomes mean to you?
Well, isn't that a loaded question? So I think the reason we're doing this is outcomes mean something different to everybody. But to me, it means a way of communicating, an easy way for you to communicate to me the value of the program that you did so that I can then communicate it internally. Now that's like kind of like the 30-second answer versus the long multi-hour conversation we've all had in different environments. But it's really, how can you brag about what you did or so that I can share it internally?
Marlene, you work in an academic setting. What do outcomes mean to you?
Well, I think there. What?
I said, be honest.
Well, I think this is a good seminar for us to really discuss it. And even in our pre-discussions that we had in preparation of today, we want to be in a position where we are looking at outcomes to understand what our funders are looking for so that we're providing that. And hopefully that our education is meeting that need as well as the needs of our clinicians so that they're providing we're getting better outcomes for patients. But I think part of what we've looked at from Purdue's perspective is to start thinking about, are there other ways that we can address outcomes? And one of the things that we're looking at is this summer, we're going to start a project to determine how we can identify what data is useful and then what we can do with that data so that we can bridge some of the data gaps between the different data sources that are out there, so that we can hopefully provide more robust outcomes, not only for our funders, but for our clinicians and our patients. We just recently at the School of Nursing picked up a new faculty member that we are going to be collaborating with, and his name is Zachary Haas, and he actually is a statistician and received his MS and PhD from Purdue in statistics and economics, and with a specialty area in healthcare. So I think it will be interesting to have him look at what we're doing from outcomes today and how that is impacted by what we can maybe look at for the data that we're getting to maybe see things differently or gather things differently or do something differently with the information, so that we're really identifying what's useful.
Mhm.
And that makes for better CE activities going forward.
Absolutely. That's a nice addition to your outcomes methodology that you can include him. Karen, I have this question for you, and it could be a loaded question. I'll probably throw it to others as well. In your opinion, how has Moore's outcomes level helped or hurt our industry?
Oh, it is a loaded question, but I also want everyone else to chime in on this too. You know, I've thought a lot about this, and I think that I've gone through my own evolution in terms of how I've thought about Moore's. I think that Moore's, you know, there's no arguing that how important Moore's has been to our industry overall. You know, it's given us a framework, it's given us a paradigm, some way to understand this sort of amorphous concept of outcomes, and we're measuring education and maybe it's behavior, and I don't know, there's some self-reports, and also we, you know, there's a business aspect involved and an academia aspect, and then also this you know, pharmaceutical you know, funding aspect as well, and you know, so I think that Moore's was a tremendous base, you know, and I don't think that outcomes would be where it is today without Moore's. That said, I think that to understand the impact of educational activities from this linear, individualized perspective, I just don't think that it's realistic. So I think that now that, you know, I do feel that the industry has sort of gotten on the same page, or at least we're you know, we all understand what we're talking about now. I think that, or maybe we're getting there. I mean, now I remember, you know, the OSP outcome standardization project is, you know, underway. So we're getting there. But I think that I think where we need to think about expanding and evolving further is, you know, where do we take Moore's now? You know, and you know, systems approaches aren't for everyone. You know, we have to also acknowledge the limitations of our field. And I've certainly had to check myself now that I'm on the other side, and I see, you know, what I thought was doable on the provider side, I realize, you know, from the supporter side, perhaps isn't doable, but that's okay. So long answer, and it was probably rambling, but I hope that it got some people thinking, and please, to my co-panelists, pick up from there if you would.
Yeah, Shanda, do you have an opinion on this?
Yes, I do. So I agree with Karen. I think that Moore's has given us a framework in which we can now that we kind of are on the same page of like what we're looking for and expecting. So it's been very important in providing that for the industry. And I agree that we need to move forward and it needs to evolve into something a little bit more. What that more is, I'm not sure, but we're having the conversations, and these conversations like this are sparking interest, and it is going to help propel and help with the innovation that is needed in our field. So that's my opinion, that Moores has been very beneficial in providing a framework. And at the time, and now that we're learning more about adult learning theories and learning preferences, styles, and we're getting more technology involved, that we now need to kind of think about it, that we might have to move a little bit, we need to kind of evolve. And Moores, it has been useful, but we might have to start looking at some other models as well.
Mm-hmm. Greg,
Sure.
talk about this, and this is a open-ended question for sure. What do you think?
So yeah, certainly, and I agree with Karen and Shanda. I think where we are now is that I think when you have a framework like Moores, when you have something that's so well structured, it makes people think that everything within that structure is the same. And we know it's not. And I think that's the problem that we're having with this whole standardization thing, is that we can't assume that because someone says theirs is a level 3, it's going to be equal and similar to every other level 3. Level 4, same thing. And we know that's not true. And we know that, especially when we start getting up the ladder a little bit, when we talk about, a performance or a level 5 outcomes, we know it's not the same, or people have different interpretations of what that is. So we have this structure, but everyone's using it differently. And then what kind of model is that if everyone's not using it the same way?
Mm-hmm. Mm-hmm. Great, good point. So what would happen if we abandon Moores and let the provider and the supporter interpret outcomes on their own?
Isn't that what's happening right now anyway?
I think in certain circumstances it is. I think that's pretty accurate. What about now taking this a little bit back to what Mary said of reporting to stakeholders? So my understanding is, Moores is pretty well understood among our industry and our colleagues, but supporters have to report to their stakeholders. Academia has stakeholders they may have to report to, and they're not always on the same page as us as far as Moores levels. So, Mary, this question is back to you. How do you envision translating, or how do you translate Moores levels when you're reporting outcomes to your stakeholders?
So I'm going to comment on Greg's comment first, is that I don't think that we're all, we're not all renegade running around making up our own outcomes model. So I go back to the fact that we do have a foundation, and how people interpret them, how organizations interpret them are very different. And our team is constantly going back for clarifications or validation on, okay, you're saying this is a level 6, but not really. And so we're doing those conversations all of the time. So I would say that in my personal experience of doing it, is that I typically, when I'm talking to my stakeholders, I don't use the Moores level, because I don't have a lot of time. And I'm not going to eat up any of my time explaining something to them of how I measure. What they want to understand is, what did you support, and why? So when communicating with my stakeholders, don't use the Moores model. I use more the term that we're all used to using and talking about how education or grant making impacted the ultimate care of a patient. So I don't use that verbiage typically internally.
Mm-hmm. Shanda, what about you?
I agree. So we have our system is based on the Moores, and that's how we collect our data and get into it. But then what I have to do is just transpose that into something that's meaningful for our internal stakeholders, in which they are looking at what's the percentage of the, healthcare providers that we've impacted, and how is that going to trickle down and help the patient? What is that patient impact? So I agree that when you come internal, we do have to change the language and make it into something that our internal stakeholders can understand and know. I mean, they've seen the Moore's models, but I agree, when you have limited time, you can't go through it. So you have to kind of speak their talk. So I always have to, almost translate the data for them.
Right. Karen, what about you?
This is complicated. I think that we have to think about measurement and research and data and the way that we look at it from kind of a wider perspective, and understand that Moore's is this very pretty kind of typical linear model of measurement. Okay, so if you break that model, it's not necessarily going, rebelling and going wild, it's that's not what's happening. Because still the measurement is the same. It's just the way in which you organize the data and the way in which you interpret it. And I think the most important thing that we can do and what we must do is validate and prove and show the impact of the education. And it's great if you can show the impact of the education on a specific patient population, but I mean that's pretty difficult as a direct correlate. So I think that as kind of Greg suggested, we have to be creative and we have to be targeted and we have to be thoughtful about the way in which we present the data to our stakeholders. And I think that Moore's almost gives us a language that we use internally, right? So it's how we speak to each other in the industry. But our medical directors, our stakeholders, they're constantly changing. There's just no way that they're going to be able to sort of hold on to that. And to be honest with you, it's pretty limited, the Moore's levels, if you're thinking of truly demonstrating impact. So the way that I present data and the methodology that I use is specific to every different team. It's unique, but it's also unique to the education itself. Not every, as Greg said, not every program is the same. Not every level 3 is the same. And I don't think that we should treat it that way. So I guess I would say I would challenge everyone to really start to think about outcomes in a different manner. Than just sort of like, okay, this is our structure, this is what we use, and breaking it in any way is just kind of stepping way too outside the box. And again, I mean, we're here to demonstrate impact, and I think that's what we need to do. Otherwise, why are we doing this?
Right. So here's my question then. Since it sounds like the panelist supporters here take our outcomes and manipulate it and repackage it into language that's helpful for your stakeholders, does it make sense that providers start putting outcomes reports and reporting outcomes back to you in a more effective manner? So we're not just to our Moore's levels when we're trying to interpret the success of a program.
Is that to me?
Yeah,
Okay.
Shonda, that would be for you.
Okay. That would be helpful, but the problem comes in, like Karen said, is that we have different stakeholders for each company, and it will make it more difficult for the providers. And I know personally, being on both sides, I am sympathetic to the plight of the providers. And I know like what my internal stakeholders might want, need, or how they interpret the data, what they find, the most important about what an IME program is to offer is might be different than what is at Regeneron. So that's why I was saying like how the Moore's model kind of helps you with that framework. So like when I put it in the system, I'm able to get, if you understand what exactly, if you provide me the right numbers, I can interpret the data and translate it appropriately for my internal stakeholders. So that way you're not having to reinvent. Okay, Novo wants this, somebody else wants this, and I just think it'll get too messy personally. But it would be helpful if we could get the data that exactly the way we need it and when we want it, and make my job a lot easier. But I think it'll make yours harder. So it's a trade-off.
It is. I think, like you said, every organization has different requirements. Some have been, at least from what we've seen so far, some have been more vocal and tell us up front, which is really helpful. Greg, I know that you work with a lot of med-ed companies as well as supporters, and you probably know firsthand those who have specific requirements. And knowing that up front, I think helps quite a bit when we are planning our outcomes, methodology, and reporting. Thoughts on that?
Yeah, sure. And I don't think the answer is another system. I think it's not like, well, this system isn't quite adequate, let's build a whole new system and start from scratch. I don't think that's it. I do think that there's a lot of good points here, that it's a good internal system. We know it's been 10 years. We're speaking that language. We're able to talk amongst ourselves about what this kind of means and have an order for it. But now maybe it's just the interactions with the supporters is probably necessary to say, okay, what do you really need? What are you really getting out of this data? How can I help you, make your point better? Because ultimately that'll help make me, help me get the next grant and help me move forward too. So I think it's a lot of that interplay. It's trying to understand the dynamics there of like, how are you taking this data and interpreting it? And are you interpreting it the way I'm interpreting it? And maybe let's have this dialogue and see what we can do. So right. I don't think it's necessarily let's start from scratch. I think we've got our language here, but maybe let's get beyond that and see what else we can do with it.
Mm-hmm. Marlene, Scott, do you have a question?
Yeah, let me chime in with this one question that came over. It sort of relates a little bit to this. So, so does qualitative data fall into the Moore's model? Are you guys seeing more of it, less of it, the same amount of it these days in outcomes reports? And is it something that providers should continue to focus on?
Mary, you want to take that one?
Yeah, I think the qualitative piece is really important. I think how it is categorized or shared with us is a part that remains unclear, in that, we still get lists and lists and lists of responses to survey questions or feedback they've got. And that, to be quite honest, is, if someone takes the time to sit and go through that, it's important, but it takes a lot of time. So to be able to take that qualitative information and put it in a format and in a way that is easily for us to consume and share. And there's lots of ways we've seen that done that. We've seen it with word clouds. We've seen it with different ways of sharing the information, but to put it in a way that it makes it so that it's impactful and something we can share, I find that is important.
Mm-hmm.
I think qualitative data is becoming more common, and that could be from several different reasons. Some of it's, I think limited response to survey questions leads someone to maybe try to get richer data out of the responses they get. And I think there's value there. And certainly in qualitative data can fit the Moore's model. It just depends on the question you ask. So there's a difference between asking someone to describe the mechanism of action of a drug versus how are they going to approach management of a patient. And I think you can do the spectrum just based off of qualitative data alone.
Mm-hmm. Karen, do you have some thoughts on the qualitative data and its place now in outcomes?
I mean, I think that qualitative data is extremely important, and I like it as a kind of a correlate to more objective data. I think that our approach at Regeneron is really about telling your story. So your outcome story. And so if part of that story is, more of a sort of, not subjective data in some way, then that's okay. But it's about telling the specific story of the impact that your education had. So yes, we are integrating it much more now. But I think that the typical, not to go back and beat on Moore's, but I think that the typical, sort of like evaluation and that sort of, as Mary said, it's just like reams of data and you know, it's just very hard to kind of pull out you know, the specific themes. So so that's how we approach it.
Yeah, and if I can add to Karen's comment, there is that I think sometimes you find the hidden impacts of a program or of education in some of that qualitative information. And what I value is when we review grants or we get feedback about, you know, here's what this grant did, this is how impactful it was, or here's what this series of grants were, and this is how it impacted. That's great. Moore's model, I understand it. We'll pressure test it. But then the follow on this is, but something we got in the, you know, in the open feedback is causing us to pause and look at this. And whether it's new learning objectives, whether it's there's a problem out there, or there's a gap out there that we didn't even know existed. I think those are the pieces where you can use that qualitative information to differentiate differentiate your grant from the others in the information you got out of it.
Yeah, it's very rare to get an aha moment from a pre-post question. You would have to have thought of the exact right question to ask, and then if you already know the question, then you already know the answer. So,
yeah, and Greg, I'll call out, you know, some, you know, research we did with CE Outcomes a couple years ago. The open-ended questions or the feedback that we got in that category blew your guys' socks off. I mean, you guys were like, wow, we've never had this many open-ended, you know, feedback in the research you've done. And for us, we were really impacted by that. We read through all of that. Those patient stories and information was really, really incredible. And it did help us tell a different story internally when we shared that information.
Right. It allows you to pull in some emotion to it. And that's something that is really hard to get from a typical outcomes assessment.
And Greg, that's what was going to be my comment. You know, for the pretty straightforward one-off activity that's delivered in an online setting, how likely are you going to get more than 5 or 6 people to answer the open-ended questions?
You'd be surprised, especially if it's a question that's ringing true and an emotional question. If you're asking the question correctly, if you're asking, you know, again, what's the mechanism of action of a drug, blah blah blah. But if you're asking how are you doing something differently, or what aspect of this education are you now doing differently? What are you doing in your practice? Can you name a patient case that you're addressing differently because of this? And, you know, they can start talking about specific patients. They can talk about experiences, and then you're starting to get some real data.
Mm-hmm. Okay. Yep. Marlene, I'm going to shift gears a little bit. So we've been talking about stakeholders and reporting. Supporters, you know, have to report to their stakeholders. Do you have stakeholders as an academic center that you have to report to? And can you use outcomes, or are you using your outcomes to show your value?
Currently, I would say no. And that's not to say that it's not important from that, you know, from that perspective, but my stakeholders are different stakeholders. You know, what we're trying to do is be able to bring in revenue to the university. And the way to do that, obviously, is if we are partnered with great medical education companies and companies like Greg's, CE Outcomes, to really come up with programming that is going to be of interest to funders so that we get the commercial support that we need. So it's not so much stakeholders from within the university, but just from the standpoint of, if we're going to be a successful accredited provider, the outcomes are important.
Right. And you're working closely with those education providers and the med ed companies that you're working with to ensure that the outcomes are robust and at the level, Moore's level, that were intended.
Right. We probably work with 12 to 14 different medical education company partners. And as everybody said, we're all working under the Moore's level of outcomes to hopefully look at what's important about what we've done, what's important about the education that we've provided, to show that there's going to be behavioral change and that there's going to be impact so that we have better outcomes for ultimately the patients. So part of, my role as a provider, as an accredited provider from Purdue University, is to ensure that the outcomes are significant, that the reports are providing what the funders are needing for their stakeholders, but also that are showing the information that is needed. And I think that's why, Greg said earlier, we don't need to recreate the wheel. And Karen said it too, we're looking at a linear product from the Moore's outcomes. Are there ways that we can take that information that we currently are collecting and glean different information, glean information that really is impactful, that we aren't at that level yet? I think that's why I find it exciting to be able to maybe peel the onion back another layer and start looking at how can we take some of this information that we've been collecting since 2009 and really look at it differently and look at it to fulfill our funders' requirements, even though they may all have different requirements. And what is it maybe that we're not gleaning today that we need to be looking at that would help be impactful for the outcomes that we provide in the future?
Yeah, and I found that with the amount of online activities and online courses and really just the technology that online activities permit, that the data that's there is so much more than a pre and post. And for years, it was always, well, let's just pull the pre and post and that's what we'll report on. But the behaviors that are going on within the activity sometimes show more than the pre and post test data. So that for us has been one of those eye-opening revelations where we said, we have to take a step back and start looking at what's going on within the activity. Mary, this question is for you. We've talked about Moore's levels, we've talked about stakeholders. What are you looking for in an outcomes report?
I'm not sure that I can list for you exactly what I would say we're looking for. One of the things I'll say is that something that we're not getting much of, and I know that there's been lots of conversation about this, is executive summaries, 2 or 3 slides that very quickly will identify, kind of the core tenets of the grant, what happened, and here's what the results were. Something that when, we're getting ready to run off to a meeting, we can go and pull a couple slides to brag about the work that we're supporting. So from an executive summary, I would say that that's an easy answer. And I'm sure the next question is going to be what should be in that executive summary. And I think what's in the executive summary is different request to request. So I would say executive summary, and then the balance of it, I'm not sure I can go through a list other than, I personally like to see, I like to see pre and post questions. I like to see if there's paired data. I like to see, charts and graphs and things that make it easier to tell the story. So I don't think any of those are really revolutionary, but anything that can help tell that story quickly is what I think is most impactful.
Karen, what about you? I know that Regeneron, has been vocal and open about what you guys are looking for.
So yes, so we have developed the educational impact summary, which I guess would be an executive summary, although I think it goes further than that because it really could stand. I mean, it is the impact of the education in its entirety. And depending on the program, that could be 1 slide to maybe 3 slides. And the way in which I constructed it is based on it's based on the way in which everyone is already collecting data. So there's nothing new. And I think that's something that we also need to kind of keep in mind that, whatever model we evolve to as an industry or whatever different models each of us use, if we're collecting pre and post data, then it's all the same. It's just how you're cutting it. even if every supporter is asking for something different, it's not that much of an adjustment if you really think about it. So anyway, so we have the our educational impact summary, and I guess at the beginning of the year we invited all of our providers who have active grants with us to come to Tarrytown to Regeneron, and we went through for I think 8 hours, maybe 5 or 8 hours, in all the minutia of what we expect, what good looks like, what bad looks like. We had an open discussion amongst all the providers and the distribution companies as well. So we've tried to be as transparent as we can, because I think that our belief is that outcomes, this is not a compliance issue. This is something that we can be transparent about. This is about reporting, and this is about the impact of the education. So that's our approach.
Okay.
So Amanda, there's a good question that just came over on the ASAM text line that sort of fits in. I think it's a good segue at this point. So here's the question: how valuable is the publication or presentation of outcomes at clinical meetings to supporters? Does it help with your stakeholders, or is it usually too far after a program to matter?
That's a good one. I think that timeline was something that I had on my list as well. Shonda, do you want to take a stab at this one?
Sure. So the question is how valuable. So if you're presenting some outcomes from a data at a large meeting, we find that very helpful, because that kind of shows the value of the educational impact. Because we've had some of our quality improvement programs that are, long-term programs that are 2 years, and we know that it's going to take a while to kind of report out. And so as long as you're keeping us posted, we're fine, because our internal stakeholders really don't know when a program has started. They just see that end product, and to have it presented for us, like it was at the American Diabetes Association meeting, to have an oral and we've had posters there. That's very impressive to our internal stakeholders, to say that, as a result of this CME program, they've been invited to give a session talk on, what this program and an impact. So, it's very important to us. Sometimes, when it is something on a topic, ours is it was on insulin improvement, and we give updates and highlights throughout the life cycle of a project as it's going on, so they're aware of it. But to have that impact at a invited Congress or symposium is wonderful.
I see heads nodding across agreement.
I think one of the things that's so valuable about that is they understand the evaluation process, the peer review process that it takes, or the requirements to get it, either something accepted as a poster or as a oral presentation. They very quickly, our internal stakeholders understand if we've got a poster that was accepted at ACR, they understand very, very quickly the criteria that it took to meet that, those expectations, and for them to understand the quality of the material and the quality of the programs we're supporting. It's really, really quick for them to understand that. So I do understand that time lapse is difficult, and sometimes it's way after the program happened, but I still think our internal stakeholders very quickly understand the value of it and grasp the importance of it. So anytime something shows up in a publication or at a Congress, that a poster is accepted, we love that opportunity to share that with our internal stakeholders.
Great. I know it's hard. It's definitely hard. We've submitted abstracts, and they are hard to get accepted. So I can only imagine that when one gets accepted, it's very good internally. Do you, Shonda, have a process in place that helps you obtain the information that you need for your stakeholders? I know that you had said that you use your grant system. Is there a process that you go through with your grantees to get that information?
Well, when you submit outcomes, it's all supposedly supposed to be automated, where you're getting these emails in which we are asking you for certain data in our system. So everybody, all of the providers, when you get a grant from Novo Nordisk, you need to submit your outcomes data through the system. So, but if there is something that we need, and in larger projects in which we are project managing it and we're talking to you, we might ask you for some extra information, at different time points. But it's basically we rely on our grant management system to do the data collection for us.
Okay. This question is for Greg, because you work closely, again, with the supporters and with MedEd companies. So storytelling and outcomes, whose responsibility is it? Is it the provider, or is it the supporter who has to report to their stakeholders?
I really think it's the role of the one who is conducting the education to tell the story of what they did and why it was important. It's a continuance from the grant that was submitted. This is what I plan on doing. Something happened, and this is what I did, and this is why it worked, why it didn't work, what I'm doing next time. I mean, I think it's role, it's the person who did the group that did the education's role to tell the story of that education. Now, once it goes to a supporter, then it might be a more of a team effort in trying to understand what it is how do you take it to the next level. I don't think that it's necessarily the role of the person or again the group doing the education to know exactly the needs of each individual supporter.
Mm-hmm. Yeah, I think that has always been helpful for us to be able to have the discussion with the supporter once a report is developed. If they have questions or, hey, we're looking for this information, can you get that or include it? And this is how we like to see it. I know that's always helpful because sometimes it's a guessing game. Sometimes we know some of the parameters, but sometimes we have data that we don't think is important and it actually is important to the supporter.
Right. No one can tell the story better than the person who actually lived the education.
Mm-hmm. Mm-hmm. So here's a question for the panel, and it's on Moore's level 5 outcomes. I think that level 5 has been thrown around quite a bit loosely in a variety of settings, as loose as a self-report follow-up survey versus some more in-depth approaches. So, Greg, can you talk through some various ways of obtaining level 5 data?
Sure. Any way you can get data, you can get level 5 data. It doesn't really matter. It's just the way you're asking the question and the way you're interpreting the data. All right, I'm going to put a caveat on that. You probably can't get level 5 data from a pre-post test. There's not enough time to make change. But you can get level 5 data from a survey. You can get it from an interview. You can get it from a chart. You can get it from patient questionnaire. You can get it. There's lots of different ways you can get it. And I guess this is kind of what it all comes back to, is that the fact that you can get it from so many places makes it really hard to compare to across the board. So, we can list examples of different what level 5 is and what it isn't. But I think it's kind of an open question. It really depends.
Mm-hmm. Karen, do you have anything addition to that?
I mean, I would say that I completely agree with Greg and would just add that, I think that at least for us, level 5 self-report is not going to cut it. It has been demonstrated to me, at least multiple times, that learners don't always know what they don't know. Mm-hmm. So, I think that a combination of maybe many of these sources that he's listed actually tells a nice behavioral story, right? So, I mean, I would agree. I think, it's funny because I'm seeing a lot of the grants that come in now. It used to be everything was level 5. And now I'm seeing a sort of like a sort of pushback. And now there's a lot of level 4, which is fine. Not everything needs to be level 5. And so, I feel that shift in the open question of what is level 5 is certainly happening across our industry.
I think one of the problems that I used to see, and I don't see it quite as much anymore, is that I think level 5 got to be such a buzzword that everyone was wanting to include in a grant. So for instance, we would have a call with a group to say, okay, well, we need some help with level 5 outcomes. We're like, okay, sure, let's see your learning objectives. And they're all knowledge learning objectives. Like, well, why are we even trying to get performance level outcomes if this education that's not, you've got maybe a drug that's not on the market yet. You've got, and you're trying to show that the physicians are doing something different with their patients based off of the education that they can't do anything with. And then we, at the end of the day, like, okay, we'll do something. At the end of the day, show it, there's no effect. All right, great. All right, now we're back to, we spent how many, I don't know, $100,000, ultimately at the end of the day, trying to get something that we never should have done in the first place. But I think we're getting better, but I think I would go back to learning objectives. What are your learning objectives? What are you trying to achieve with your program? And if you're not trying to achieve performance change, there's no reason to try to measure it.
Mm-hmm. Mm-hmm. And can one single activity change behavior?
No. Shonda, no.
Probably not. But right now there's not there is a way. And if you want to talk about a way, you can talk to me after this, to really measure multiple activities. But it's difficult, right? Because we all know that learners don't change their opinion, don't change especially their performance based off of an hour-long presentation. It's very unlikely.
Yeah. So I would still say, or what I've gathered is that if you can do a follow-up survey and ask that question, go ahead, get the data, find out if people are going to self-report that they've made changes, but it might not hold as much weight as we once thought it did a couple of years ago. Mm-hmm. Mary, you're shaking your head. Yeah.
Yeah, I would agree. I can a self-reported level 5, is anybody that's ever talked to me about it has ever heard me say is, I just don't, there's way too many times that people just don't report the facts because their perception of what they're doing is different. And, an old colleague of mine said this really well. She said, intent to change. Ask me on January 1st, am I going to lose 30 pounds? And then, in the next six months, and then in June, put me on a scale and weigh me, and let me see what happened, because my intent to change, I was going to do it, but those donuts won every time, right? And so, but I think that, to me, that's how it is what our intent is and what we actually have the ability to execute and do are often very, very different things. And so when we start getting like solid level 4, I'm good with, and even level 6, if we can truly measure it, but level 5 in the self-reported, I get really uncomfortable there. But I want to go back to something Greg said a minute ago, is that, I think we talk a lot about level 4 and level 5 and level 6, and, that's what we need. And we need to get, our outcomes have to be higher and higher and better. But sometimes it's okay just to do awareness building and to put a grant in the system to say, hey, look, we just want to let people know about this. That's good. Call it what it is and measure it like it's going to be. But not every grant has to be, level 4, 5, and 6 education, because they shouldn't be. But I think sometimes everybody thinks that we need to get it, they've got to be higher and they've got to be more complex. And I would challenge that to say that that's not always the best purpose, to Greg's point, based on the learning objectives of what you're trying to achieve.
Yeah. Good point. Here's a question for our supporters. And Shonda, we'll start with you. Has Novo Nordisk implemented an outcomes day or a day where providers come in and showcase some of the activities that you supported to the rest of your organization?
No, we have not. We're thinking about it because we're hearing more and more companies are doing that. But we have done it, like we had some projects like the quality improvement initiatives. I have invited those providers to come in and speak to some of our medical affairs colleagues and marketing colleagues. So it hasn't been where I've invited multiple people in, but like if it's an individual project that I think that, have very good outcomes and impact, and a program that I know that they will be interested in, I have invited the providers in to speak to that.
Okay. Mary, what about AbbVie? Does AbbVie do that?
No, we have talked about it, and it is something that the team has looked at doing, and we hope to do a broader provider day or however we want to call that. We're looking to do that in the future. We do bring individual providers in to meet with our team, and in some cases an expanded team, but we have not done it as a standard course of business to date.
Mm-hmm. And Karen, I know that you said that you just did it not too long ago. Is this something that you intend to do annually, quarterly?
Well, it wasn't providers sharing their data though. It was us sharing with them.
Yep.
And as the other said, we sort of do it on a case-by-case basis. The reality is it's very hard to get all of these people in one room together, even within a therapeutic area team, but to get them across therapeutic area teams, that would be quite a feat. And wonderful. But time is valuable and it's difficult. So, to be honest, I think that we'll probably keep on case by case basis when it comes to providers sharing their outcomes with us. But who knows, if we're able to demonstrate our impact to our internal stakeholders and we become more salient in their lives, then maybe, yes, they would, we could get everybody together and have a true provider day where everyone is showing the best of their best outcomes.
Yeah. Well, and outcomes are what helps us, make our case, right?
Yes.
Marlene, I have a question from you, again, from the academic provider point of view and really accessing potential resources around you. You had mentioned that you are adding someone this summer from the School of Nursing to look at data. Have you ever relied on, or is it a possibility as an academic provider, and could you suggest that to other academic providers to leverage access to students, interns, and residents with your CME department, and how could you take advantage of those potentially low-cost labor?
Well, I'm pretty flexible and always open to new ideas. So I think anything's an option. Now, we have used students for helping to gather data. More importantly, I think we've used faculty to help define needs assessments with our medical education company partners. Even though a lot of the companies have their own medical directors and teams, a lot of our faculty are up to date on the latest and greatest as it relates to guidelines for new drugs that are coming out for the various disease states. So we have set up conference calls. I've offered that, and sometimes I've been asked where some of our faculty for a particular disease state will be on a call with one of our medical education company partners so that we can really talk about what's happening in that particular disease arena and how they can help with a stronger needs assessment in identifying the practice gaps and putting together a meaningful program. So I think there are a lot of options, and we certainly take advantage of them. And I would suggest that others in my position do the same kind of thing, because it really ends up being, I think, a broader and a lot of different ideas come together to make, I think, a stronger program.
Right.
Stronger proposal.
So we are at our final minute of our session, and in summary, it definitely sounds like Moore's outcomes level has helped create a framework and some common language among our community and our industry, but it really is time for us to go beyond Moore's, especially when we're reporting and making sure that we are telling a story that is going to help you, the supporter, tell the story to your stakeholders. I really appreciate everyone's time today. We had some great insights from all of our panelists, and appreciate everyone joining me. So thank you.
All right. Well, great. Well, thank you, Amanda. Thank you, everyone. Just a quick note for those of you who are watching this session live or watching the recorded version, there is a very quick survey. We will be gathering level 23 outcomes for CME Palooza this year. So it's a quick seven question survey that does help us plan for the future and get a sense of how we did for the spring. And so with that, for those folks who are watching this live, there is one more session coming up. So when this session ends, wait about 30 seconds, refresh your browser, and the next session will start at the top of the hour. So I'd like to thank Amanda and Greg and Karen and Marlene and Mary and Shunda for their time and insight, and we'll see everyone soon.
Thank you.
Thank you.